you to hear my voice.
I want you to hear
Unless, hello, testing, testing. No, bad. No, not working.
You can only hear it through the video stream.
Because we are streaming, right?
Correct.
Okay, so we
So
will.
that's why when you said you had videos and stuff, and I know this computer was working. I don't know if the audio is still working.
That.
Um,
Gosh, I didn't think about that piece.
You know what we're doing. You get the front seat. All right.
We get nervous, we'll look to you, so you have to smile at us.
You said what?
I said when we get nervous, we'll look to you, so you have to smile at us now.
Oh, no problem. Oh, honey, you get all kinds of smiles. I got you there. I understand. So
we can try to screen read to that. That's the
That's why you
screen
the tech guy.
This is mine.
I thought that was yours. Close it up there like that. Got something to
All right, sounds good. Do you?
Good morning, everyone. Hopefully, you all can hear me. I do apologize for the tardiness. It's great to see you. It's good to see some familiar faces. Go ahead. We're going to pause for just 2 and 2, like Chuck Willery, for technical difficulties.
So we're live streaming now.
Oh, we are live.
Yeah. So would you like to introduce yourself first?
Sure. Hello. My name is Cheron Phillips, and am with the Elevate Collaborative, and that's a part of the Integrated Health Network. And I'm here representing Community Voice as a patient turned partner today.
And good afternoon, everyone. Thank you for joining us. My name is Nia Plump. I talk really quietly, so I'll try to speak up. I'm also here representing Elevate, and like Sharon said, we work through the St. Louis Integrated Health Network, working on a perinatal health equity program to bring more positive outcomes for Black women in Missouri. So I'll be taking the slides today. If you want to quickly go over the agenda with everyone.
Okay. All right. So here on our agenda today, of course, we just had our introductions here. We're going to go over an Elevate Collaborative overview, the community collaborator testimonies, our challenges, successes, and hopes, and closings. And we're going to have a little bit of time for questions and Q&A. Maybe. Hopefully you got some questions for me. And again, my name is Cheron, and again, I'm representing patient turned partner, just representing community voice. That's what I would say it overall. Okay. And of course, my partner, Nia. And I also want to disclose that this is a shared work from a dedicated collaborative of organizations and community collaborators, and that does include federally qualified health centers and academic medical colleges. And we have been entrusted to represent them today in discussing both our successes and our challenges. And the first question is you good. All right, so I'll go ahead and give this over to Nia here so she can go ahead and what I missed. Sure.
So I'll talk a little bit more about the St. Louis Integrated Health Network specifically. So what we describe ourselves as is an intermediary, right, between healthcare systems and community-based organizations or community as a whole. We know that there's a strong history of mistrust between these individual organizations. And so what we try to do is improve health equity throughout the St. Louis and throughout the Missouri region, and try to connect some of those partnerships that have been lost along the way. Okay. And so this is our racial equity statement. We thought that it was really important to create a racial equity statement because it creates transparency and also holds us accountable to what we say we're going to do as an organization. And now we're going to show you all a video that talks a little bit more about Elevate specifically, which is one of the perinatal health equity programs with the St. Louis Integrated Health Network. It's okay. We will talk a lot about Elevate today. But really, what I really wanted to show you all the video for was because Cheron did a fantastic job putting that video together, actually. And I was hoping that you would speak more about why we created that video for Elevate, talk a little bit more about your experience with Elevate, and just kind of go through what the process was like for creating that video, right? Because this is your first time editing and sort of creating something like that, right?
Yes. Okay, so this video was very important for me to kind of put together. It was initiated, the process of making that video was initiated because they were trying to figure out how to get more people into the group sessions, into the classroom. And my idea was, if we're going to collaborate, we probably need to start some promotion. We need to start talking about it more, because I'm a mom. I can go out here and talk about it, but where am I going to get the information? I mean, I'm only going to have a baby this time, you know. So with that, we decided to bring together some patients, some of the moms that was already a part of our group. Are you okay with presenting a video, just giving a brief little synopsis about how did Elevate affect your life? How did this program help you? And then we also invited the providers, and of course we're working with multiple providers from different organizations, all come together, and they all agreed to come to the table and let's have this conversation about hearing of the voice of the community. And this is around power dynamics, okay? Because in this community is usually the doctor is always right, and so but this was an opportunity as a patient to be able to kind of not necessarily level with them, you know, let's see eye to eye, let's collaborate together. We asked that the providers dress down and remove their white coats for this particular opportunity, because we are trying to reduce the power dynamic and have a real conversation. There was a situation that happened in this process where there was some physicians who decided to continue to wear their white coat, and at the time they were, you know, they continued to wear it even in the interview. We didn't like take it off, you know, but but we were just giving you the option to do that. And in seeing that in this process, what I saw was there was a lot of people who gonna have a struggle with relinquishing some of that power. Okay. And only thing that kind of hurt me about it, how I felt a little bit about it, is because before this moment, she was the favorite on the floor. Everybody know her. She the coolest midwife, and everybody. She's just the girl. She got a nickname, and she cool with everybody. But then when it was time for her to, behind closed doors, they call it integrity, when nobody's looking, how she felt about these people that she was working with every day, it showed. It really seeped through the cracks. And I think that moment, it changed a lot about, and it made me feel like, now I know why we got to do it. It's people like me that need to be up here to express that. And then said, oh, sure. We'll go to the next slide. Y'all mind if I sit down? Okay. Well, let's go ahead and talk about it. All right. Honestly, all right. Woo! It's okay. God got me. All right. My question, go ahead.
I was asking if you wanted to go to the next slide. Oh, yeah. I'll sit down too. This is a conversation, right? That's something that we do with our providers and our patients, right? Is when we circle them up for them to do group prenatal care, which I'll talk a little bit more about shortly, it isn't the physician standing talking at the patient the entire time. With group prenatal care, you have your regular appointment or your check-in, but then after that you stay for up to 90 minutes with that physician, and everyone sits in a circle. You're with folks of a similar gestational age as you, and you work through a curriculum together. And so I just wanted to talk a little bit more about that, since you guys didn't get to see the video. But now we're going to talk about why we do this work, though. And I actually have a heat map to show you all that we put together. So we have a couple different clinical sites. A lot of them are Affinia Healthcare, which is a federally qualified health center in St. Louis. We also have locations in Kansas City. And as you all can see, a lot of the concentrations of those heat maps are concentrations of where Missouri residents have had preterm births. Those are very dangerous. And yes, they are very much in alignment with our zip codes where we live, right? Or where I'm assuming folks are coming from. And so one of the reasons why we do this work is because we know that zip codes can determine people's access to health care. It can determine their birthing outcomes, such as preterm birth weight, and all, like early delivery, all kinds of things, right? Which is incredibly scary. And so one of the things, or can you all hear me okay? Sorry about that. The mic is on, but it's for the live stream. Yeah. So I'll try to project my voice a little bit more. So what I was saying before was that this heat map kind of shows us the distribution of where the preterm births happen in Missouri. And these statistics can be really scary. And so one of the things that we decided to do, we knew that these outcomes were happening for Black women, for people across the Missouri region. And something that we wanted to do was bring together providers who were already practicing group prenatal care, because group prenatal care has fantastic outcomes for Black women and for other participants as well. And so in 2016, in the basement of Affinia, providers came together from all types of clinics, right? And some of them even being competitors with one another to say, how can we improve these outcomes for Black women in Missouri? So I do want to talk about in the early days of bringing these folks together soon. But first, I'll tell you a little bit more about the health inequities that are faced in Missouri. So I'm sure you all are very familiar with the Missouri Pregnancy Associated Mortality Review, and here's a QR code of it in case you all want to take a look at their report. And I have some information both from the recent one that came out, which was the 2018 to 2022, and then also the 2018 to 2021. And so some of the maternal health inequities that still exist in Missouri are the pregnancy-related mortality rates in Missouri, which are like 2.5 times higher for Black women. There's also mental health challenges, and 79% of the deaths that have happened in Missouri that were associated with mental health conditions or have a history of substance abuse were determined to be preventable. And then there's also all kinds of scary health outcomes for the infants in Missouri as well. And you all can take a look at that report in more detail afterwards if you would like. And so I'll talk a little bit more about Elevate. And so we have like 3 tiers of intervention that we want to focus on, right? Because we know that group prenatal care works, right? It has all these fantastic outcomes, but there are other things that need to be considered, right? So there's the patient level, which is reducing these inequitable health outcomes, but there's also healthcare teams to think about and healthcare systems that perpetuate medical racism, that perpetuate stigma and cycles of harm in the healthcare system. And so what we wanted to do was also provide trainings for healthcare teams and communities to support patients who are experiencing toxic stress from racism, from depression. And also we wanted to target healthcare systems. And so we wanted to create shared accountability between the networks that they have as well as the patients that they serve. And I'll talk a little bit more about group prenatal care as well. So like I said before, you would work through a curriculum together with folks of a similar gestational age for up to 90 minutes. And Elevate's curriculum is a little bit different because it incorporates mental health therapies into it, such as cognitive behavioral therapy, mindfulness, and so it's a little bit different than typical curriculums which might focus on family planning, nutrition, but it really tries to dig deep, and it also incorporates very anti-racist principles into them. And the providers really have to be intimately aware of the activities that they're doing when they're working with patients. And then I'll talk a little bit more about the clinical side of group prenatal care, which is that group prenatal care has an association with improved mental health. There have been tons of studies that have shown that it has been supportive in reducing perinatal depression, improving folks' feelings of self-efficacy, better interpersonal communication. And then there's also an associated reduced risk of preterm birth with a subgroup analysis of Black women specifically. And then Black women in group prenatal care are 45% less likely to have a preterm birth if they participate in group prenatal care, which is incredible. And then next, I wanted to talk a little bit more about how we figure that group prenatal care is uniquely suited to promote health equity. And I was talking a little bit more about focusing on the psychosocial stress and depression that is experienced through racism, right? But also acknowledging the barriers that are in place and will continue to be in place in the separation, right? The privilege that providers may hold in working with their patients, something that can't really be ignored. Okay. And so finally, our overall goal really is to completely change how systemic racism is impacting patients, right? We know that this is a big goal of ours, and this is definitely something that we want to work towards. Our model is intentionally very anti-racist, is informed with trauma-informed care. All of our providers have to go through anti-racist training and trauma-informed care training. We spent a lot of time just acknowledging biases, acknowledging power dynamics not only with providers but also the researchers, our evaluation team. And so it didn't start and stop there. We know that a single instance of training is not going to be sufficient to break down these barriers in care. Okay, so next I'll talk about why we do this through the St. Louis Integrated Health Network, as opposed to doing it through research or academic institution. So something that community-based organizations have more experience with is centering patients most impacted by health inequities, right? And so I have with me today Cheron, right, who is one of our patients' term partners. And we really wanted to have patients, I want to say Elevate had one singular meeting without a patient there. And the providers realized right away, actually we need community voice. We don't need to design studies without patients here in the room with us telling us what they need, what they've experienced, what the impact has been of group prenatal care in the past, and also prenatal care in general in Missouri, right? And so, and I touched on this a little bit, but training by itself is insufficient. It has to be a complete acknowledgement of unconscious and conscious biases, and also like multiple instances of working with partners, working with patients, and then hosting and fostering collaboration between these institutions that might be in competition with one another is very important. And so separating the research institution and adding in a community-based organization has been incredibly impactful in that way. And then something else that we wanted to do, which is provide ongoing training. And also a part of our study is looking at empathy or clinician empathy, right? Like when we decided to study or evaluate Elevate, we didn't want to focus on just, do we know that this intervention works for mothers? Because we already know that it works for Black mothers, but we really wanted to focus on why, and we wanted to focus on the providers and how they're also impacted by group prenatal care. Okay. So finally, we operate off of a saying that is nothing for us without us. I'm sure you all have heard that at some point because St. Louis loves that saying, and I do too, which is why I incorporated it into this PowerPoint. But really, we didn't want to ever make decisions without having patients present, without having the community present for whatever it is that we wanted to do. Thank you, Cheron. Okay. And then we also didn't want more of the same, right? Because we know that academic institutions benefit greatly from doing research. And so it's very easy for them to go into communities and or extract what they need and leave the rest and leave people without resources. And so something that's incredible about Elevate is just the fact that not anyone, but our patients really they have kind of soared in this position and being with us. And I actually was interested in hearing a little bit from you soon, if that's okay, about what your experience has been like. So I'll talk a little bit more about the process of bringing on community collaborators, and then I'll let Cheron talk, because I've been talking at you all for quite a while now. Okay, so what was our process? So like I said before, we had maybe one meeting without patients present, and decided that that was the only meeting we wanted to have without patients present. And so the community collaborators are all folks who have experienced prenatal care in the Missouri region, or they have participated in Elevate group prenatal care or some sort of form of group prenatal care in general. And so what we do is we invited folks on, but we didn't want to say, I'm bringing you to the table and this is it, right? It's one thing to invite folks in and say, you can sit in on this meeting, but we're not going to help you. We're not going to facilitate. We're not going to listen to anything that you say, which often happens a lot, unfortunately. But really, we created a steering committee that kind of guides our decision making, and everyone is collaborating on that. Our steering committee is made up of social workers, public health professionals, community collaborators, researchers, providers, like anyone that you can think of that has group prenatal care experience in any way, or has any interest in like breaking down systemic barriers. We kind of brought them all together, and we really turned to the patients and said, what do you want to do? Right? And so a part of our dissemination and development has pretty much just been letting the community collaborators inform the work that we do, whether that's they do all the trauma-informed care training. It's actually fantastic. Like watching them, like watching Cheron be in her element is amazing. And also one of the ways that we sustain this work is by making sure that anytime we apply for any grant, whether it's programmatic or research focused, they are paid stipends at an equitable rate, because we want to acknowledge that this work shouldn't be voluntary, that people should be recognized for their lived experiences, and they should be compensated for that work and for what they do. And so we never want to bring in patients and say, hello, can you do free labor for us? Because Black women should be paid what they're worth. And then I'll talk just a little bit more about our collaborative goals, a little bit more about how we're formed, and then I'll let you talk. I'm sorry. And so one of our primary goals is to center folks who have been impacted by racial inequities. We really want to have a cultural shift in the medical room, right? Like we really want folks to enter into the space totally different. We want to incorporate mental health exchanges. We want them to be able to anticipate or perinatal mood and anxiety disorders. We just want to disrupt racism at the root causes of where it comes from with these inequities. And then we also wanted to integrate emotional wellness skills during pregnancy that would extend beyond. One of the like best things that I've ever heard is that during a conflict management portion of the curriculum, somebody took that information home and they worked through it with their partner. And it just made me feel so happy inside to hear that it was something that was sustained outside of the like patient or the group prenatal care setting. So, and now I will stop talking finally and give the mic to you.
Well, I guess the question would be, what was my experience like being involved in Elevate? And I could say it started off in the early journey where we had 10 sessions, 2 hours long every week. It was like a one-stop shop for behavioral health, prenatal care, all rolled in one. And I can say that when I was invited, I was excited because for one, before I have 4 children total. My first child was a vaginal birth, and everything worked out. 10 years later, though, now I'm in Elevate, and this seems like a very new pregnancy. Okay, my partner and I had pretty much just met. Now we having a baby. We gonna stick together. And before then, all I had when I had my first child was this book called What to Expect When Expecting, and that is all. And my mama, and so that's it, you know. And so having this opportunity to be offered to come to a group where I can talk about it with other moms, I thought that was very important, because a lot of times pregnant people get deemed as complaining, and, you know, you asking somebody, girl, you're going to be okay, blah, 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 you know, and you got all these questions. So this was opportunity to get in front of other groups of moms and say, hey, you too? Oh, wow. You know what I'm saying? Or how y'all handling it? The other great thing about Elevate was that I was able to bring my support partner, whether it be the father of my child, a sister, or mother. But during these groups, because it's so intimate, they ask that if you bring somebody, try to keep it consistent, because what we talk about here, we want to make sure that we keep it here, you know. And but having my partner be involved in my care, not just a 15-minute visit with my provider, but we sat down for 2 hours with other groups of parenting couples as well. And the guys end up connecting, talking about video games, and we was hyped, like, oh my God, they like it. So, you know, we was really hyped. And then the ladies was feeling like, okay, wow, this is cool. I actually get to ask questions, they answer. We talking about breastfeeding, we talking about discipline. holidays, how we gonna do that? And a lot of these questions, because me and my partner were really new, we hadn't even got to that yet. You know what I'm saying? We still on 21 questions. All right. So now we're be able to talk about other things now. Now we need to talk about how we're going to raise this child together. And we didn't get to discuss it all in class, but it opened up an opportunity for us to take this information home and for us to like talk about it together and really make a family plan. So I really appreciate that aspect of it. While we were there, we would all sit around in groups and have our conversations. We passed the wine and we got rules on the wall and don't yuck my yum. It's a whole process. And I thought, wow, they offer us snacks. Pregnant moms love snacks, guys. I learned that grapes and cheese are good together. Okay. They give us a lot of healthy stuff too, but even when you're in a group, if you got other things to do, like other testing, I had to do a lot of stress tests. So, in the group, once it's over, my stress test is scheduled immediately after. I don't get pulled out of my group. It's just, we know your appointment is from this time to this time. Okay, your stress test is going to be immediately following, and you stay the next 30 minutes, and then you can go home. Any other testing I had to do was all done right before or right after my appointment, or my group, prenatal care. And we did our weight. We checked, we did workbooks. They gave us workbooks, y'all. I felt like for the first time, this is like a new pregnancy for me, technically. For the first time, I'm actually like really doing this. At first pregnancy, it was like, ah. Okay, then the second pregnancy, I was screaming, but then I got somebody to come to help me, and we doing it together, and that felt really good. And then being able to, after this moment I thought was so great, the people called me back and invited me to come, and they said, we really enjoy your opinion, and other moms may enjoy that as well. Do you mind coming to have a seat at the table so we can talk about this? And I'm thinking they want to hear what I got to say out of all the people in the world, but I mean, I'm gonna give it to them real, because you want to tell the truth. It's like they want to do a live survey. So what you think about it? I thought it was good, and I gave them my true, honest answer. And that's how I became part of the committee. And in that process, they started talking about, I felt that we need to share this information with other moms. And that's how the video ended up coming about and things like that. And at that moment, I learned how to get in good trouble, because I saw what happened with their white coat situation, and it encouraged me to keep going. And from there, I continued to grow. I became a community health worker. I was so proud, y'all. My family was there, and I still use the community health worker fight in me as I move forward in other positions. So I always say there's good trouble. So at my job, at my regular job, I'm gonna be the one standing up. I'm the one that caused chaos, but it ain't like for the bad. It's for the good, because I'm fighting for the good. So I'll be a shield. And going through this process, I learned that I'm a shield for my community. I'm a shield for other people. And sometimes a lot of people, also, when we was going through this, it's like the providers and stuff, they all got they feelings too. You know what I'm saying? They really feel something behind it, but they can't say it because they boss in the room, they coworkers in the room. You got the white people and the black people in the room, and stuff you don't want to say, you don't want to offend nobody. Call me. I'ma say it. I'ma say it. I'ma say it straight face, and I'm gonna be real honest with you. That's why I'm here. To stir it up. And what they gonna do to me, as a community person, I ain't got nothing to lose. I'm already gone. You know what I'm saying? We don't want no more Subway sandwiches. We don't want no more pizza. Okay? I've been doing this for 8 years now, and I feel like I appreciate Elevate for offering us stipends, because that's what happens. I'm like, they getting all that information, the business is still rolling, but I'm still in the hood. I'm still poor. I still gotta, you know what I'm saying? I mean, this is like a part-time job. They asking me to come here and do all these talks and share this information, share my experience with you. People are here doing book tours. I ain't got no book. But how am I going to get paid for the gas to and from? You know what I'm saying? I still, hours out the day. I'm taking time off work and stuff like that to come in and share my story. And that's why I appreciate Elevate for really seeing community and allowing us to like express ourselves and express what really happens. And that's why, y'all couldn't see it, but you can always go check it out on YouTube, okay? It's out there. You look up the Elevate Collaborative video, you'll see the moms who we started with. And we all had our kids together. The doctors, you'll see what I was talking about too, okay? And I really appreciate that of Elevate. And like I say, I've just continued to use that community health worker spirit of kicking down doors and being a shield and being community voice in my career, and it has taken me on. I'm a case manager now. I help people. I've worked and I feel like I'm in all the sectors. Like, I don't necessarily jump from organization to organization, but I teach trauma-informed care. I do facilitate with one of the other moms that were with. Her name is Rochelle Smith. She's not here today, but we do this all the time. We've traveled. We went all over the country talking about trauma-informed care to providers, nurses, and we do it to people who are just about to graduate residency, because we want you to know what to expect before you get out there, that you're going to run into people like me. And I want you to have the opportunity to listen to people. Don't, give them a chance. And I also feel like the providers can use their education and my experience to come together, and we can collaborate and come up with an answer, because I can tell you how I feel and you can tell me what you know, and then we can work on something, a better plan. I had a lot of fight with my doctors, and I got put, let me tell y'all for real, they put me they put in my medical records that I was like confrontational or like combative, okay? And that made me so mad, because I was like, all I was saying is that my first pregnancy was vaginal, my second pregnancy was a C-section, my third pregnancy was a C-section, my fourth pregnancy was a C-section. So I was trying to fight on the third and fourth to get back vaginal. But they kept saying, no, just because of the last one, I think you got to. And so we tussling. And because I kept asking questions, I wasn't yelling or nothing like that, but I was like asking, well, so why? I mean, but what's the reason? Can you show me what I do? What's the number? Show me the data. Like, but they just, and so that's when, I started talking with other community people, and then the word got around, like, so are they trying to have more C-sections because they get paid more money? And that became another big old question to the providers. And what we learned is that they said, well, honestly, I don't think it's that they get more money. It's just faster. Just do it faster. But why you want to do fast, but I'm going to have a lifetime score? You know what I'm saying? I understand, because I'm a case manager on my day job, and some people they want to go fast, but I'm still a person, and this still a life-changing decision. And honestly, I've never had surgery outside of having a C-section, so that's why it was so scary. And I'm fighting, like, please, let's try it another way. Let's see what we can do. And I feel like by them putting me down as combative, it said a lot. You don't like when people buck back and to challenge your educational. I'm not saying that you're wrong. I'm just saying work with me. I don't know how to bring it back around, but I just wanted to tell y'all, elevate good, okay?
We kind of jumped around a little bit, but it's okay. If you guys did want to hear more about our implementation process, we do have a curriculum committee on top of our steering committee. We also have an evaluation team, and our patient-centered partners are also part of our evaluation team and curriculum team, because we really want to have their voice everywhere. Like, they are quite literally saying, this is what we want in terms of, do we want to do qualitative interviews to receive information from providers and patients, things like that. So now I'll talk a little bit more about this concept of like a seat at the table. I really like this saying, because like I said before, it's there. You have many opportunities to bring folks in, but what does it really mean when you say this table? You have a seat here, but is it accessible? Not in like an ADA way, even though that is important. But are you people listening to you? Are they validating you? Are your opinions and your decisions actually impacting what's happening moving forward? And also, do you feel like you have to use academic language, right, to communicate with the folks that you're interacting with? Because we have a lot of doctors, we have a lot of academics at the table. And then something else that I like to talk about is like, can everyone make it to the table in terms of when are we meeting? So we meet after hours. We don't meet during traditional business hours. Like, folks will be having dinner and hanging out with babies or children sometimes during those meetings, but we really want as many people to join us as possible. And then we also say, or I like to say, does everyone have the same chair? Talking more about like that input of who is being listened to and who is the expert here, because really we want to trust community to be experts of their own decisions, or experts of their own lives, and kind of inform what we're doing, and we're just kind of allowing them to guide that process. And so I wanted to use this as like this metaphor as like a stepping off point, because we have had to acknowledge power dynamics throughout this process, right? Or like you said, acknowledging white coats and what does that mean in a room when you bring people in together. And so extending that invitation was just the first step, but then what else did we need to do to move forward? And so some challenges that we've experienced in the past is just like transparency. We want to be transparent about everything. Whose data is it that, who has access to this data, right? Who's getting listed on authorship, for example? We want to talk more about like equitable decision making. So we have like a decision matrix that we use now. We want to disrupt power hoarding. And we also want to have empathy for capacity, right? In terms of, I'm bringing you to this collaborative, but what do you have space for? What do you have like emotional space for? Because sometimes when we're doing trauma-informed care, or even when we did a presentation similar to this, folks can get really personal about their lived experiences, right? And that requires a lot of vulnerability, and it requires a lot of trust on us to say, it's okay to share this with these folks, right? And so we also want to move away from that all or nothing mindset when we're bringing community in, where it's like, you have to come to every meeting, you have to make decisions on everything, you have to read all the applications that we submit, all of that, because that's really overwhelming, right? Like, if I was just like handing off my job to everyone else, that would be incredibly stressful because they already have their 9 to 5. And so we wanted to move away from that all or nothing mindset where like we're asking folks to interview for grants, we're asking folks to like fill out surveys and all these things, right? And then something else that we need to acknowledge and that is always present are just the inherent social hierarchies that exist as a result of years and years of medical mistrust, medical racism, racism in research, and capitalizing off of the Black body. And so we have spent a ton of time talking with physicians about power and privilege, intersectionality, St. Louis, its history, and how that all folds in to create the patient experience and how they may be supporting that or how ways that they can disrupt that. And then asking physicians to be vulnerable too, right? Because when you're sitting in a group with someone for 90 minutes, it's kind of impossible not to talk about yourself. And so leaning into what professional vulnerability may look like for a provider is really interesting because people do kind of get shy at first. And so they have been challenged in many ways to acknowledge all of these biases, all of these systems that are happening, and then also like their personal lives. And then some successes that we've had are provider involvement. We have many Elevate champions, which I am very happy about, and many of them have acknowledged the inherent biases that are present. And then some folks have fallen off, and that's okay, right? We prioritize anti-racism and trauma-informed care principles, so we have trained well over 250 providers at this point in trauma-informed care. And then something else that we wanted to do was like deconstruct and disrupt traditional professionalism and reliance on data alone. So bringing in that lived experience, bringing in qualitative or like mixed methods for different like research activities that we do. And then some successes as well as like decision making. So we have our steering committee. When we bring people in, we level set with them, right? Because we don't want to say, here's this data, here's this like super jargony research. We expect you to know exactly what this means and we're just gonna move forward. That isn't fair to anyone. So we do a lot of level setting. We created our own racial equity statement and values alongside of the IHN's racial equity statement. We operate out of non-traditional business hours. We operate on the collective versus like the few to make decisions. And then we challenge the status quo both internally and externally with our clinical partners in terms of their policies and practices that they have. And sometimes that quite literally looks like, can we have a physical space where Elevate can happen so that folks can have this area where they go in and they have the privacy to do what they need to do for their like clinical stuff, and then we come back out into this bigger group. And sometimes it just looks as simple as that. So something that we've been able to do with leveraging the skills of our community collaborators and their families has just been creating a portfolio of trainings and trauma-informed care trainings for folks. And you all are like listed on a lot of research like at this point on like different abstracts and things, just like activities that we've done over the past like almost 10 years now. because it'll be 10 years in 2026. So shared ownership and authorships, right? Having folks listen on websites, abstracts, brochures, promotional materials, and doing our shared work acknowledgments at anything that we do. So there's also the stipends and compensation, and then transportation, just making sure that we can actually physically have people move from one space to the other. Like, we have gone up to DC together, and sometimes that quite literally just looks like me going to go pick up Cheron. So looking to the future, and some of the other successes that I haven't mentioned is one of the similar policy disruptions. So we've actually been able to get additional reimbursements for providers who practice group prenatal care, because we know there is a cost associated with it. And so something that providers can do now is through Medicaid, they can bill for group prenatal care. They have to say that they spent 90 minutes with the patient or similar language. And so we are looking at policy implementation, how to get uptake for that, and also looking at the long-term impacts both in St. Louis, Kansas City, and Missouri as a whole. Something that we want to continue to do is support clinical sites, and then onboard new clinical sites as well, and even encourage them to start creating their own methods of contacting or equitably reaching out to community members to say, how do we implement your voice, and how do we share with you the policies that we have, and how can we improve those policies. And then support and eliminate, I feel like our biggest goal, right? Our biggest goal imaginable is to eliminate racial inequities. That sounds like a big goal, right? But then there's all the folks that contribute to the system that we operate in, that we all make decisions together and as a collective. And so I believe it's feasible. What do you think?
I think we can. We've been working towards it. We've gotten close, but we haven't completed the mission. And so we're going to need more Cherons out there to kind of stick it up and say. And we need more physicians and providers who are willing to listen and willing to kind of shimmy the white coat down just a little bit to have a real conversation, because we're real people. So I definitely think it is attainable. It is an attainable goal, but there are a lot of objectives that we need to conquer before we're able to complete that goal.
Okay, and so if you all wanted to hear more from us, like Cheron said, we have a YouTube channel and also a website where you all can take down our information. You are also welcome to take down my email. You can take down Cheron's email if you're okay with that. Yeah. And I'll leave that QR code up for a little bit, but I did also leave 10 extra minutes for questions or Q&A, just in case you guys had questions about the collaborative, or you wanted to know more about our implementation process, our research, or anything like that. Yes, ma'am.
So where are you all located?
Mhm. So Elevate doesn't have one specific clinical site that we operate out of, because we have multiple different sites with Affinia, multiple different sites in Kansas City. There's a couple different folks practicing group prenatal care with BJC as well. And so multiple places? Okay. Yeah. It's a little bit hard to promote Elevate because of that, but once you break it down, it's like you either go to, you pick what clinical site you want, and then you move forward from there. Yeah. Yes, ma'am. No, it's okay.
So you said that you have the different sites. So where are the group sessions being conducted?
Yeah. So at the clinical sites. Yes.
Okay, so they're actually at those sites.
Yes.
You all have some that's kind of apart, in a community center type form.
I mean, I would.
Not in a community center, but more like a federally qualified health center,
Yeah.
and not necessarily like the O'Fallon Community Rec Center. It's more of the reason why it's in a medical place, because it's still a doctor's appointment.
Something like that. In
Mm-hmm.
conjunction, which is great.
Correct.
The reason why I was just asking, because we have spaces, in the dental office.
Uh-huh.
So that's one of the things that kind of made my ears perk up,
Mhm.
that this is such a great, thing to have that group type setting. And if you all do that apart from, the actual appointment, and, just to get more information, just to get more, I guess, support.
Yeah.
for that.
If there is a space, let us know. We will try to be done. Yes.
Yeah. Well, there you go. Yes. Do you? We have multiple questions. Do you guys want to?
Pass the mic.
And then I'll just try to speak on it.
Yeah, to just kind of build on that, how did you go about to be able to line up the group with the appointment? What does that take in order to be able to just make that so seamless?
We have coordinators at every site, and so they will look out for folks who are interested in doing group prenatal care. They'll kind of ask them if do they want to, and from there, they'll find folks of a similar gestational age, and then they'll pick up. Usually, it's around like the 13-week mark or so that folks kind of really start to align. So.
Yeah, I wanted to circle back to the white coat. I have a really good voice.
Oh, well, just for the record.
So circling back to the white coat issue, I was curious about two things. Number one is if you observed any difference in how the community members related to and communicated with the medical professionals who were willing to shed their white coats and be more on a one-to-one. Was there a perceptible difference? And I also was curious when you used female pronouns to refer to the medical person who wouldn't remove the white coat, and it just struck me to wonder if that's because she had to prove her credibility to her other gendered peers. So just curious about that.
Thank you. Oh, go ahead.
Well, I'll answer your first question, which was that you mentioned, was there an observable difference? We're currently under evaluation right now. So we have all these qualitative interviews. We have some quantitative information as well. And we're sort of studying all of that right now and putting it together and organizing it in something that is digestible. But I actually something that I was interested in talking to you about when we had this conversation originally was just acknowledging the fact that midwives and OBGYNs are treated very differently in the medical space, and if you thought that might have impacted her willingness or unwillingness to sort of like shed some of the, I guess, layers of academia or however you want to say it.
I can say that personally, I can't speak for all the people, but for myself, I can say for the ones that were willing to, I saw them differently, but in a good way, like, that's a real person. You know what I'm saying? That person I know really cares. That means when we're not around, they're still going to continue to fight. The ones that just now, if that person needed to prove themselves in their field, I totally understand. Because midwives had a little fight not too long ago about being respected. Okay, so I could totally understand that. But this is not about you or me alone. This is about us as a collective. And as a collective, we trying to hold hands together. And we need to be able to do that together. And we gon', they say together we stand and divided we fall. And I think that at that moment, it was an opportunity for her. So it was a lesson for her on the back end, to see how community still showed up. They still was able to express themselves and say how they felt. But after that, I think they probably saw her like, oh, maybe she may have a personal fight going on with internally, but this was about us as a group. So I can't say it affected the other moms, but me, I know now I'm still going to treat her the same. I'm still going to speak to her at the grocery store. I'm going to treat her just the same. But now I know. and yeah. So, but that's it. But if she does have some type of fight with being a doctor and an OBGYN, I don't know how to help that fight. You know what I'm saying? I don't know how to help that.
Well, the whole thing is a great lesson to all of us about taking off our armor or whatever that means in whatever sense. So
Yeah. Thank you. And yes.
What does the group prenatal care model look like in rural communities? And how does that work? Because and I'm wondering if you can go back to the heat map that you had, because I noticed a lot of counties didn't have any data, and often that means that there is not sufficient data, but that doesn't mean that there aren't preterm births and maternal deaths happening in those communities. So how does a model like this, how does it look in rural communities?
Fantastic question. I alone do not know the answer to that, right? I think it's going to take the collaborative and also folks outside of the collaborative to figure out what that means, right? Because access to care in general is so difficult, especially right now with the federal changes that are happening. I am just kind of afraid to even think about what could happen, right? But it's funny that you asked that because folks are interested in bringing group prenatal care to rural communities. So I don't know. Do you have any thoughts? Yeah, I would turn it back to you guys, actually.
I was gonna say, well, I'm from the city, so I haven't been in a rural area, but I have traveled a little bit, and I've seen a couple different sites, and some of the issues were low numbers in attendance coming to the groups. It could be for various reasons, but the issues that people in the city have versus the people in the rural areas have are different. You know, with their environmental circumstances are different, which would change the reason why they are showing up or not showing up. And we haven't been in that space yet to see what those issues are, to maybe say how we can offer more assistance to them. But the only thing I would possibly think would be what I've seen is just getting the numbers, getting the promotion out there. Do people go to the doctor as often as they need to? I don't. We want to catch them as early as possible. Convince them to bring their partner, convince them to bring some support if they have support. There's a few different factors there. And also in those areas, when we're talking about racial equity in those rural areas, I don't know how Black patients or patients of color are being treated in those rural areas. Me personally, I am strong enough to go in those areas and be able to speak, but I have been in some of those tight spaces, y'all. And let me tell you, the meeting after the meeting get a little, you know, I've been in some of those tight spaces. So I can say that it would be working on the power dynamics between the provider and the patients, and it's a lot of different factors that play into that. And I'm not sure exactly how it will go, but I can tell you from where I've been, I've seen a few things that could potentially happen.
My other thought is just that something that has been incredibly impactful is home visits for rural populations. And so I'm even wondering, is group prenatal care what you need? But I think in practice it would look like a ton of like transportation and education on the front end, right? To make sure folks can even go there, and tons of incentives, because a lot of our clinics also have incentives, like you get so many diapers, you get, you know, so many like bucks to spend at like some sort of like shop that they have, which I thought was really innovative and cool. But did you have a question?
I work for the Missouri Rural Health Association, so if anyone wants to talk more about rural stuff, you can come find me.
Yes.
We're working very hard to get doulas and midwives trained in these spaces, because if you look in the blue teal right there, so those like New Madrid, Scott, and Butler, those are really tight counties for a lot of causes of death and obviously preterm births. So we are working really hard to try to address that, because the group can be really tricky when you don't have very many people.
Yeah.
So anyway, I'm Libby. You can take my card.
Okay. I would like your card after this, Libby.
I would love that too. Y'all are great.
We are right at time. Does anyone have any last questions before we break? Yeah.
About like what happens after there's a baby. So obviously like this focused a lot on prenatal care, and it seemed like it would be really building kind of like a foundation for a support system that would hopefully like follow through once there's a baby. But I'm curious, like, does any of that support exist in like a formal way through this work? And if not, what do you think are like the opportunities there or the gaps in the systems to make that possible? Because things are hard when there's a baby.
So I'll be fully transparent in saying a lot of folks don't make it to their 6-week or their like postpartum visits they're supposed to come to, which is understandable because like you said, things are hard once there's a baby. Something that we've been thinking about is how to capture moms through the pediatric appointments rather than trying to get them to come to their 6-week postpartum visit. But there isn't anything formally structured to keep moms talking to each other. Sometimes groups get really close and they have group chats, or they have like different pathways that they use to keep in touch with one another, and sometimes they don't. And so that's one of the things that we're interested in looking at now is how do we also add support on the back end, where we know that this is like one of the more dangerous time periods for moms, is like that year postpartum, right? But thank you for bringing that up, because it's really important. Yeah.
Quick comment. I have noticed that gap, patient turn partner. And so what I did was I created a small community group called For Parent for Baby for Life. And it's not like 501c3 or anything like that, but I brought it to the table to, like, you know, the powers that be, and they, you know, it's something that they're working on that stage after, because I said it all the time. Now that the baby's here and all the people then hugged and kissed and all the gifts and stuff like that, now mom, and they need you, and mom needs you really, really bad. And so that's what I've been trying to do, is work on the postpartum care, how to get diapers and continue to breastfeed and encourage those type of things like that. So it's in the works, and even the conversation about how we implement dads into the fold of the conversation. So those things are in the works. Thank you all so much. You've been great.
Thank you guys so much for your attention. I'll pull her.